Davis Sampaio, Chief Officer of Diversity and Inclusion at Share Cancer Support, and I'm delighted to introduce our next session. Latinas in the U.S. face differences in healthcare access, socioeconomic status, acculturation, and preferred language, which uniquely contribute to health disparities. In addition, cultural values such as fatalismo have been shown to impact breast and cervical cancer risk and screening in women. Community health workers known as promotoras or patient navigators work within communities to provide health education and prevention in culturally and linguistically appropriate ways. Our Latinx same-race sessions explores these very important issues as they discuss navigating towards personalized, quality cancer care. Our moderator for this discussion is Isabel Durong, founder of the Latino Cancer Institute. Joining this discussion are Dr. Gisemi Lopez from USC Norris Comprehensive Cancer Center, Dr. Mabel Maldones from Rocky Mountain Cancer Center, and Dr. Patricia Chalela from the Institute for Health Promotion Research. Welcome.
In the Latina community are your issues. Our battles are more similar than they are different. Our challenges are just as daunting in some cases as yours. With while fewer Latinas get breast cancer, about 1 in 10 in 100,000 compared to 1 in 8 non-Hispanic white women, we have disproportionately high mortality rates due to late detection, exacerbated by the lack of awareness, the access to standard care, late detection, knowledge and access to cutting-edge care. Breast cancer is the #1 cause of cancer in the Latina community, and it is the leading cause of death. In the advocacy battle for quality care, there are 60 million Latinos in this country, with about 1/3 of them pushing up against the systems that are not working for the most vulnerable in our population. And so when we are talking about a standard of care, when we are talking about equity, we are not just talking about equality. That is, everyone benefits from the same sorts. We're not even talking just about equity, where everyone gets the support that they need. What we're talking about actually here is justice. As you can see, everybody can see the game without support or accommodation. But because the cause of the inequity, once the cause of the inequity was addressed, the systematic barrier has been removed, then we are moving towards quality, equitable care. That is social justice. So our framework for discussion today with our fabulous 3 Latinas here who are the experts and who have lived experiences both professionally as well as personally across the set of issues we're going to discuss. Gisemi Lopez from Los Angeles, a 2-time survivor of metastatic and thyroid cancer, who turned her challenges into helping other Spanish-speaking breast cancer patients navigate a confusing system. Patricia Chalela from UT San Antonio, a researcher who spent her professional lifetime finding answers that can translate from theory into practical applications, bench to bedside, you've heard, for the Latina community and other marginalized groups. And Mabel Madonas from Denver, a rare bird, an oncologist and researcher who, like most of us, had to confront her own barriers to succeed as a Latina in a medical world where there are so few like her, so that she could come to that place where she could champion the needs of Latinas facing one of the most fearful battles of their life. So we know that poverty is I call it the real predictor of social determinants of health. Some people say it is a social determinant of health. And I'm going to turn to my colleague, Dr. Patricia Chalela, who's going to pick up that theme before we get our conversation started. Welcome, Patricia.
Thank you, Isabel. It's a pleasure to be here, an honor really to be part of this panel and talk about these important issues. So I would like to talk or to continue the talk that just Isabel started about social determinants of health. But before that, let's frame what are health disparities. So health disparities are due to a complex and dynamic interplay of biology, social determinant of health, and includes socioeconomic and environmental factors, structural system factors that involves the healthcare system, healthcare providers, and also patient-related that involve, for example, cultural factors such as language, beliefs, values, and traditions. So it's important for us to reflect on something. Health begins where we live, where we learn, where we work and play, in our homes, in our work, in our schools and communities. In other words, outside the doctor's office and long before the illness starts. So if we look, for example, at the slide, socioeconomic and environmental factors account for about 40 or determine about 50% of our health. 30% is due to health behaviors and 20% due to health care. So let's look a little bit at socioeconomic and factors. If we look at socioeconomic factors, including education and income, just looking at those two, these are the most critical factors affecting health and longevity. They influence the prevalence of underlying risk factors for cancer, access to health care, health insurance, and affect the entire cancer care continuum from preventive care, early detection, diagnosis, and treatment to survivorship care. So, and we know that Latinos, we are more likely to have lower levels of education, lower income, and lack health insurance. Other social factors also influence our health. For example, if we talk about our culture, language, beliefs, values, traditions, they may also influence our health prevention actions and medical care. One of the things that sometimes I said is sometimes it's difficult to get, for example, Latino men into a screening because they don't believe they need to go to see the doctor if they are not sick. That's something, just a simple example. Other behaviors, the individual behavior, for example, also affect our health or determine our health. We said before, and it's in the slide, 30%. However, individual behaviors are not only determined by our individual choices. Socioeconomic and environmental factors shape individuals' opportunities and barriers to engage in healthy behaviors. For example, we all know that having a healthy life, a healthy diet, maintaining a healthy weight, and doing more exercise, physical activity, are key to stay healthy. However, we need to have a budget that allows us to buy fruits and vegetables for our family. We need to have grocery stores in our neighborhood, and it's difficult to engage in physical activity if we have to work 3 jobs just to get by, and if we don't have access to parks or to recreational facilities in our environment.
So Dr. Shalala, you are laying out a large, long laundry list of the issues that we as a group here are going to be talking about today. Mm-hmm. So let me turn to Yasemi Lopez. Let's talk about one of the things you brought up was, access. And that goes, in some ways, part of the barrier is language. And then the quality of the content of that language, not just communication between doctor and patient, but an understanding of the material. So, Yasemi, tell me how you see it as a barrier and what you, as a navigator, have done to move that barrier, to address that barrier, or to just change it entirely.
Thank you, Isabel. Actually, language as a social determinant of health is really important for us because, as we know, in our Latino community, not only we have to deal with English, Spanish, and Portuguese as the most common Latino languages that are spoken. However, many times when we are part of this cancer experience as patients or as caregivers or navigators of these patients, we encounter that the quality of content is different from English rather than any other language. And that is a big problem. If we have a family that has a family member with a new diagnosis of cancer and they're trying to find what information is available out there, the information is very limited. And there could be a variety of reasons why many organizations or hospitals may not offer the information with the same quality of content. But it is important, especially in these times when we're talking about precision oncology, precision medicine, where we're trying to customize the medicine that is appropriate to each individual. So how can we expect to offer good quality of care if we don't have, for example, the clinical trial translated and explained in a cultural and linguistic competent manner? So I think that this is one of the main issues. And the other issue for me in language would be the use of untrained Spanish speakers to help as interpreters or translators. And I understand that only the federally sponsor programs or hospitals are mandated to offer translators, or whether it is on a phone or even on video. However, many times not all the places are able to use these interpreters or language lines. So we depend on a family member or any staff that is not trained as an interpreter to help the family. So that's a big problem.
And that was mentioned, Ivis, the whole idea of culturally competent navigators, that being promotores or community health workers.
Exactly.
I had an example of a patient who was put on the phone to be told that they were going to die because the doctor couldn't talk to them. And finally, our patient navigator was able to come along, only to discover that the gentleman spoke Mixtec, not Spanish.
Exactly, not even Spanish.
Had to work,
Yeah.
So then she had to work through a family member. And finally, when diagnosis and understood it, and his wife started crying, that's when the doctor knew that he got the message. So Dr. Mardones, you heard Dr. Lopez say something that makes you very happy. Clinical trials. We know the gap in clinical trials. If we can't even get proper educational materials to help explain basic care, how do we possibly get to clinical trials which are going to get us towards that advanced medicine and towards that that advanced care that we all hope we're going to get, that precision medicine?
That's right. Individualized care, precision medicine is really the wave of today, and it's an emphasis for a reason. I think we all deserve that level of care. So I do agree with everything that's been said so far. I think that I've seen it both as a physician myself, as a caregiver, a mother who prefers Spanish and is much more comfortable in Spanish, facilitating her care, and personally in many other dimensions. And agree completely that the quality of translation and the quality of material needs to be very, very specific. And having said that, I think two issues have come up in this conversation. As a physician who practices and cares for people with cancer every day, the emotional impact of this diagnosis is one that I think all of you would agree is challenging enough. And then when you layer on the communicational issues, you lose a lot of information as it is with this cancer diagnosis. And then bringing on unqualified translators, there's a tremendous loss thereafter. And I can't tell you how many times I meet Spanish-speaking patients who then obviously know of the Spanish lack of barrier there that we can communicate. And often, repeatedly, time and time again, is I didn't know what was being recommended. I didn't know why I had that plan. I don't know why I'm on this medicine. I don't know what a clinical trial is. So I think we all recognize these issues. And so I just wanted to bring to light that emotional impact and that quality in order to translate into clinical trials. Well, they really need to be, it's already difficult enough for an English Spanish patient to understand a clinical trial. It's hard for us, we're physicians. These are complicated dynamics for a reason. And I think that so long as we have institutional policy to maybe mandate that we have translators who are qualified to share information in such a way that at a patient level we can understand, that's how we're going to reach a level of equality when it comes to clinical trial enrollment.
Isabel, I want to add something.
Yeah, go ahead.
Adding to what Mabel just said, one of the things also is that it's not only to have a translator right there when they are communicating with the patient. Sometimes the cultural part of Latinos also is a barrier, right? So for us, doctors are an authority figure, and they may be trying to explain to us what is happening and what needs to be done, and we are doing this all the time. Yes. Do you understand or you entiende or whatever they try to say to try to communicate with a Spanish-speaking patient, and the patient is just saying that because they respect the doctor so much that they don't want to say, I don't understand. They think that that's a lack of respect. So that's one issue. The other issue is not only the translator, but also for the clinical trials, the consent forms. They have to take it home and read it, but if they are perfectly translated into Spanish, but in a very high level with technical terminology that are not explained in clear terms, is going to be like I am reading Japanese. So those are also the issues that we are confronting, and that's why it's so important to involve the patients, to make the translation, to test it with real patients to see if they understand it, and then trying to explain. I am truly believe that we need to use the technical terms because that's what they are going to listen, but we need to explain what it is about it, right? Those are some of the issues that also compile to what it has been.
And all along the conversation, I hope we're not just going to talk about the barriers, but we're going to talk about some best practices that perhaps you have personally instigated some way or another through your work that will lead, we hope, to that understanding and hopefully eventually into policy. So just send me real quickly, because I want to move on to our other themes. One best practice that you utilize and maybe even push the system a little further in order to make sure that they're getting some quality communication.
So actually, this is an excellent opportunity for us to get the community involved from the grassroots level, because we have been able to train promotoras de salud, like community health workers that are from the community, that they are able to understand the science and help us to relate to the patient in a way that it comes more natural. And that they feel they are speaking in the same language, same level, and same, what Patricia was mentioning about the health literacy is so important. So that's one of the possible solutions.
So, and you're talking about a bridge to the community and into the clinic and through the system, but you're also talking about increasing the education, because they're not just necessarily going to talk to the patient, they're going to talk to a whole group of people and help them move forward.
The community education component.
Exactly.
That they can promote, yeah.
Exactly, so, which is something that my agency used to do all the time, because without education and understanding, by the time you get to Dr. Mardones, it's like, I mean, there's a lot of fear, there's a lot of misunderstanding, there's a lot of, just inability to hear, and so you need to have some leveling there. Dr. Mardones, what do you do? Because about 10%, you told me, of your patients are Spanish speaking, because you work in a private healthcare system, but you do have about 10%, and most of them are Spanish speaking. So what do you practice differently in order to make sure that they're getting the same care as your English speaking patients are?
Right. So I think it really just starts with a level of communication that I think I'm uniquely set up to provide. I think that even though patients in that 10% almost all speak potentially English and could communicate very openly, there's a clear preference for the language to be in Spanish. And that provides a level of comfort and a level of trust that is instantly almost instilled, and obviously take that very seriously. I think that from a physician bias perspective, I come from that different side of the table, and that I think that we need to be grounded in our values as physicians when we take our oath to provide equal care to everyone. It really is as simple as that, to be honest. I think that what I offer a Latina is going to be the same thing as I provide for an American-rooted patient as it is for an African-American patient. And so I think that high quality care, if we're committed to that, it should be obviously across the board. And I think that we are set up pretty in a unique setting, and where we as shared before, we're part of the U.S. Oncology Network within a private sector, and we pride in bringing clinical trial accessibility to the community. And I think that's really where it is. If patients can have high quality care without seeking necessarily having to go out of town or out of state to seek that, I think that's where we begin equity to all. And so I think that's what we do very well within our organization.
You mentioned bias, which we can see through the whole system without even recognizing it, from our academic institutions who are teaching or not teaching, competence, nuance, understanding, all of that, to our researchers who are sometimes under-resourced. So I'm going to shoot this to Patricia Chalela. You've probably seen your share of bias in academia, maybe against your kind of research. Maybe underfunded, maybe not accepted as serious science, more public health maybe than hardcore science. How do you push back against implicit bias from the research end? And what do you think needs to be done to equalize the playing field for racial and ethnic researchers?
Yes, not only to that, but applying it to the breast cancer patients, for example, is that implicit bias is something that is unconscious, and it brings us certain stereotypes that we feel about certain people. For example, a doctor can be very kind, but when he sees a Latino patient that needs participating in a clinical trial, he may think immediately, oh, they are poor, they don't have transportation, they are not going to meet all the requirements and come to all the visits. It's better if I don't offer the clinical trials. He's not thinking all those, but unconsciously, he or she is not going to offer it because of that. That's an implicit bias, because he's assuming that the patient is not going to do it, or cannot afford it, or don't have the transportation. So one of the things that we are trying to do, right, and this is in progress, because implicit bias, all of us have it. I mean, I took the test and I was surprised that I still have some bias. So it's something that is important to raise awareness, so we know those things happen, and activate us in how to address them and avoid them, because that's very important. So one of the things is that we need to teach our medical students, when they are still learning about medicine, about implicit bias, about the importance of cultural competence, raising cultural awareness, so they can really provide care to everybody, to all the minority minority patients in an equal way. So that's one of the things that I think we should do. But that's absolutely right. We face discrimination and bias in every level of the medical care.
Yeah. But I also think because you skipped around the answer about academia, which is a big challenge oftentimes for community researchers or researchers of color trying to get the grants that need to do the work that needs to be from bench to bedside. And I think that there's a bias there, that there's a power imbalance that needs to be addressed. But I'll leave that for another day.
No, I can say something very quickly. It's that I am part of the Hispanic Serving Institution, and I'm part of the institute that involves a lot of Latinos and that work with Latino researchers, and we are trying to address Latino health disparities. So I am not experienced at work and my surroundings that limitations, but maybe regarding to the different RFAs or funding opportunities that are offered, maybe that's possible. I mean, that's
well. I mean, therein is the reason why we do have Hispanic-facing and African-American-facing institutions, because there they can support and back up and be there to be the front runners of the leaders around these issues. I mean, it's wonderful to have that opportunity, but a lot of researchers don't. I've heard the challenges for researchers who are not in these kinds of safe places. But, you know, just the other day, a Spanish-speaking woman was very depressed, called with questions about what to do because she didn't quite understand her diagnosis. It was a breast cancer diagnosis, though she was told that she knew the cancer was in her lungs and bones. And though she was at stage 4, which I thought might be metastatic, she did not seem to know or understand why the doctors who didn't speak her language wanted to cut. That's all she understood, was the word they wanted to cut. And she was depressed and she didn't know what to do and she was very anxious. This goes back to me a real bias about, I mean, Patricia started to say it, and Mabel has talked about the quality of care for each patient. They all get that same caring. But what I heard with this woman was they didn't think because she spoke Spanish that they could even take the proper amount of time to sit her down, speak to her in a language and in a way in which she understood her own diagnosis before she had to make the decisions to do what it is the doctor recommended. So that is an implicit bias to me.
Totally. And I'm glad you mentioned that because I see that in practice a lot. I go with patients to different hospitals, and like Patricia and Mabel have mentioned, because socioeconomics is such an important role in our care, and many of our Latino patients have struggled with a financial issue, so they end up going to public hospitals, the public system, and many times because of the amount of patients that are coming to these places, the limited amount of time that they get to see a doctor is so short that they don't have enough time to really get to know the patient. And many times they're just trying to fit all this information into one session of 5 minutes. I've been in appointments with some where in 5 minutes they tell them pretty much you're going to pass. And I don't think that's fair for our patients, or like you said, the implicit bias of just because a person is Latino. And I noticed that even within our own Latino experts, you know, our own Latino fellow professionals, I remember that one of the people I interacted with, she was third generation of immigrant, and she was treating this patient who was immigrant, and she's like, well, I can't relate because, you know, my grandparents were immigrants or something. But you don't have the same experience as this person. And therefore, you don't understand the same history or the cultural context of why this patient, like Patricia was saying earlier, why this person is not asking more questions, and she just kind of like keeps nodding like, yes, I will do whatever you tell me to do, even though she's not understanding a thing. Exactly. And it just breaks my heart when I see those cases. But I think coming back to your original question, how can we solve that? I think that we have to educate ourselves. We have to continuously be humble and learn more about other people's circumstances, particularly because as Latinos, we have so many ethnicities to think of. I mean, I'm married to an Argentinian, I'm Mexican. Like, we have a mix of Latino cultures that we need to learn more about and understand why for some might be more difficult to understand the news than for others, and how they will continue their care. And getting their family involved, because that's another issue. The involvement of the family is so important.
That's exactly right. And I'm going to pull you into that piece as we talk about roadblocks. Sometimes the families, due to lack of awareness, understanding, fear, misinformation, et cetera, often become the roadblock to quality care. Describe one of those for me, and then I'm going to ask Patricia, particularly because she does a lot of work around communication and around using tools in order to help the community. So I'll ask her to pick it up after that, but talk about the roadblocks.
Sure. One of the main roadblocks I see, and especially, you know, as many of our shared audience, they have like either breast or ovarian cancers, and those are obviously related to content of intimacy, sex, all these type of taboos in our communication in our families many times. And one of the cases I had to see was a patient who was newly diagnosed with ovarian cancer, and her husband didn't want her to have a male provider because, you know, the machismo a little bit there. So he force himself to be part of that first visit with the oncologist to make the decisions on the treatment. And something that it really bothered me about it, you know, to hear him answer questions, personal questions that the doctor was asking about the patient. So like the patient didn't even have a chance to speak. Like the husband kept interrupting, like just speaking about, oh yeah, her menstrual period is like this. Her, you know, like we have sex every this and this. And I was like, I can't believe he's not letting the patient speak. So I had to ask for a break from the conversation because I noticed the patient was getting very overwhelmed and she started crying. So we had to go outside, and I spoke to the husband and I say, you know, you're going to help her more if you stay outside with me right now, because this is her time. And I know you want to help, but right now it's very overwhelming for her. And
So
he helped her.
Good, because it sounds to me that education, and it's not just the patient burden or issue, it is the family issue, and they all need to be embraced and educated about that next step. So Patricia, that's some of your work, right?
Yes, absolutely. We do a lot of community outreach and education. And one of the things, of course, we develop educational materials, give presentations direct in the community, and we try to involve families. So in that way, everybody is informed of everything, that the importance of prevention when it's possible, cancer prevention and early detection. It's important to try to raise awareness and educate the community in that sense of when they need to go to see the doctor, or we try to promote, for example, participation in cancer screening. They know exactly what is going to happen when they go there. I believe that the involving the family is absolutely important among Latinos. I mean, usually it's not one patient with one family member, sometimes it's 2 or 3. It's important if the husband goes, it's important that he be there, but as Gesemic was saying, that gives the patient the opportunity to express what they are feeling. They can be there for support. If they are not going to support it, it's better to wait outside. But it's very important to involve the family, because usually health decisions as critical are related to breast cancer or ovarian cancer are taken among the family. They not only the patient. It's like, they talk with the husband, the husband with the children, and also with the mother, with the aunts, with my comadre. What do you think that I should do? So it's very important to respect that and try to embrace that part of our culture and work around that and turn it to the patient's benefit.
Right. And one of the things I've seen that works against when the family is not engaged, there oftentimes creates dysfunction because they don't know what's going on, or the response to
they don't understand.
They don't understand, or they fear what they don't know, and then they make up their minds and they either pull back, or they act out if they're children. So there's just such a need to think about the whole family in terms of a care plan.
Exactly. I mean, because something that is very important, I'm sorry that I just a little bit, and something that is very important is family support. For us Hispanics, family support is absolutely crucial. So if they are not involved in the care, if they are not involved in that awareness that we have provided, they are not going to provide the right support that the patient needs to go through the cancer care continuum.
Yeah. And Dr. Mardones, I'm sure you've seen some of that. I wanted to move this just a little down the road, coming to clinical trials, because this is so crucial. Underexplained, research under-resourced for Latinos in clinical trials, barriers galore, language, insurance, comorbidities, legal status, all become barriers to engagement. You have done what you can, how do you address, first of all, those roadblocks, where a whole family needs to be engaged, do you think, to get them to the patient to move towards a clinical trial?
Right. So I'm going to say something that is going to touch on many of the things that you guys have addressed, and it's going to get back to the root of bias. And this is going to be controversial, but I'm going to say it. The medical system has shifted from quality to quantity. And if that is the issue today, we cannot provide quality care to all, and especially for our Latinos who need more time, who need more explanation, who need more engagement. We cannot provide that because the survivorship in oncology, because science has moved so far, so quickly for the betterment of our patients, the amount of survivors in 2030 will outsource the capabilities that we will have as medical oncologists to care for people. And that will match the incidence of cancer. We will not have enough medical oncologists to treat cancer in this country. And therefore, we have to think of systematic ways to address and revert the change from back to quality. And that often will mean, because I've now been in practice, I know those roadblocks myself. And I know that I need to be healthy mentally, spiritually, and all of it to care for people with this disease. And if we are not taken care of as your providers, if we don't have boundaries, if we don't have time to go back and have time with our families, we won't have enough of us to care for our Latinas. And that's inclusive of whether I am Latina myself or someone else. So that addresses the issue. It touches on everything. It goes back to clinical trials, because if I don't have enough time and I have 5 people waiting in rooms and I have to jump from one room to the next, we are not doing this. And so where I have gone into a way of sort of addressing this issue is I am utilizing advanced care practitioners in such a way so that I can spend quality time with the people that need me at the different intersections of their care. At the time of diagnosis, I'm spending more than an hour with patients to try to be as educational as possible, because I come from an educator's background. Every single person in my family, starting with the woman who led me to this, the passion that I have for the care of cancer patients, was a survivor of cancer. She was an educator. And I tell my patients every single visit, I pride myself that at the end of this visit, if you understand why it is that I'm recommending this, this, and this, and you have a handle and you have a game plan and you are committed, your success is there to have, because they're just as committed to that plan, because there's a level of understanding. So that's what I had to say in regards to the roadblocks. And I think that's going to lead to change. I think if we can become creative as physicians and providers, let's become creative with the volume we have. Let's spend time with the people we need to at their given time frames, and let's bring in additional resources for our health.
I agree with that, but we still need to get those people into clinical trials who have issues with these other these are policies or their regulations in place that actually keep some Latinos out of clinical trials. So you not only need the education, I think, you not only need language interpreters, but you also need to remove the insurance requirements. You need to remove the comorbidity issue, which is partially the big problem for many cancer patients, is that there's already a comorbidity that put them at risk for cancer. Yeah. So I'll have you, Mabel, address that one more time, but then I want Yasemi to weigh in. So sure. You figured a way to do the clinical trials and get Latinos in, right?
Yes, absolutely. So I completely agree with you, though. I think there is an inherent bias, but that's applicable to all cultures when it comes to comorbidities. Now, I personally have not seen an issue in regards to insurance. Do recall that most clinical trials do cover cost of drugs and do cover costs of scans and labs, etc. So I haven't seen that be a specific issue, though I agree with the inclusion criteria. And that's a general issue that I think we need to address as a community in regards to adequate representation. It goes back to homogeneous representations in clinical trials, mostly white Americans who are very, very healthy. People want to push drugs, want to get them approved, and this is the way it happens. However, that's not the real world. So that goes back to policy, Isabel.
Yeah, and that's where we have to figure out where we push from, right? Or who we push, right? Yes, Emmy, please weigh in.
Wow. I have so much to say and so little time. But I think that
we have
right. I think number one, I love what you said, both of you, Patricia and Mabel. I think you nailed it. And we have to stop silos. We have to push for policy that, and even when you think about people applying for grants, many organizations, many funders are already doing that, where they are trying to improve multidisciplinary collaborations. I think it's so important because we're going to benefit from one another. But the other thing I also think it would be important is to establish policies where it reduces the amount of waiting time for patients to receive certain services, as well as to include consideration for funding, whether it is from the federal level, the NIH, the DOD grants, the PCORI grants, all the way down to the local level funders, private funders even, where we can get culturally competent programming and also budget that considers the hiring and retention of qualified staff. I think it's so important that many times we do have qualified staff, but there is no incentive. So we need to work on that and to add more people to the table to participate in committees, to bring more advocates, because that's so important.
And that goes back, Yosemite, to the issue that we've been discussing for a hugely amount of time, and that is the reimbursement of community health workers. There are some policies that support it, but mostly it needs to become under reimbursement plan, private as well as Medicaid, Medi-Cal, I guess, depending on which state you live in, and also from the federal level to support the reimbursement. I mean, Texas has a certification, but the minute you put in a certification, how does that limit your opportunity to take what you know is a community health worker and still be able to be part of that system if you don't get certified, right? Or does it eliminate you because you're not documented, and yet you're like the heart of the community, bringing them care and the support and bridging? So that's a real huge policy issue that I've been hearing about from the federal to the state to the local levels. Patricia, Mabel, what do you think about it? Because you both have mentioned the use of community health worker. Or
before that, can I say something about clinical trials?
Sure.
Something that is important for the audience to consider is that clinical trials are absolutely vital for the development of new treatments. So every single treatment that is today considered the standard treatment was before part of the clinical trials. But as everybody mentioned, if the majority of participants in clinical trials are white, non-Hispanic, and we as Hispanic Latinas do not participate in that clinical research, the generalization of results are going to be difficult, in the sense that how do I know if this specific new treatment that was developed with majority participants of white is going to respond in the same way for Latinos? So it's very critical that we participate in clinical research. And part of that solution is raise awareness in the community first, of course, among patients, but in the community, so they understand exactly why the importance of clinical trials, all the safety precautions, and all the safety. How do you say that? All the safety requirements to keep patients safe, really, do not harm. So that's one of the things. That's one thing that I wanted to say about clinical research. Yes, we use a lot of patient navigations. we truly believe that patient navigators are a bridge between the community and the medical system. And the patient navigators, based on research and part of the research that we have conducted, positively impact timely access to care, especially for Latinas, that it's very common that they, from a normal finding, when to the time that they got the definite diagnosis and treatment, the amount of delay is much longer than for regular or for white non-Latina patients. So we involve always patient navigators. They help. They are not only come from the community, they know the culture, that speak the language, and they can help navigate through a fragmented system, because we have a fragmented system. And we need to understand, based on Jessamy also say that, and Mabel, is that we cannot look at the cancer care continuum as independent, isolated silos. That's the meaning of silos, right? They are in those domains, from prevention to treatment to survivorship, are interrelated. And we need to provide a seamless cancer care. So sometimes the patient goes to the initial diagnosis, and after that, we lost the patient. Why? Because many times the doctors are talking, okay, you have this and this, and you need now a radiologist. You need to talk to a specialized oncologist on the surgeon. That is very easy to understand. But one of the patients that I talked with was like, he was telling me that a radiologist, and I was thinking in my mind, what is that? I don't understand where can I go to find that specialized care? Because when you are diagnosed with cancer, you need a multidisciplinary team. And many times all the doctors are not in the same building, so we need patient navigators are key to provide that center care. Yeah.
And Patricia, because we are now down to our last 3 minutes, I think it's crucial to just name it along that cancer continuum. So for the community, it's early education and intervention, including, I think, access to genetic testing, early intervention to diminish risk and that fourth stage tumor on the other end that may not get diagnosed timely or in the best of comprehensive care centers, but at public healthcare systems that obviously do not have the same quality of care, not because they don't give good care, but because they too are challenged and under-resourced. So that's community. Once you've got a diagnosis, what is the policy there that needs to be addressed? I talk about education and community, that has to be funded. What about diagnosis? What one policy do we need to push up against, ask to be changed or be included that will help at that early level? Patricia, Mabel, Jessamy, which one? For diagnosis.
For example, I'm going to talk about patient navigator, and then we open the floor. But something that is...
We've only got 2 minutes.
Yes, oh boy. Is that we that patient navigator are part of the medical team. Right. That's something that is very important, and we need to push that policy, that every cancer center can have that, for example. That's one.
Okay. Perfecto. I like that. Mabel, any idea there about diagnosis?
I don't think every cancer center or region is mandated to have a multidisciplinary tumor board, is my understanding. Obviously, we have that in every center where I practice and where I've trained. I think that needs to be standardized across the board.
Okay, so now we're going into care, to treatment. And so depending on where you live, the access to advanced medicine and precision care is very limited. Very limited. And if you live in rural areas, even more so limited. What are some of the first things, Mabel, maybe you, where would you think we need some policy to begin to shift that lack of access to precision care?
Well, I think it really goes back to what all of you have addressed, which is going back to we live in an era where obstruction of privacy is a real concern. Everybody's worried that our information will be disseminated. And that's a real barrier to access to clinical trials and germline genetic testing. So when we start educating patients in the community, going to where they are, where they live, where they routinely live life, and educate there about why it is that these things matter, and there's a trickle effect not only to them, but to their families, and for quality of care, that's where change begins.
And I think that when you come to survivorship and or even end of life, you need to make sure everybody has access to palliative care, understand this, as well as hospice care, quality hospice care that is bilingual, trilingual, whatever, and has the cultural understanding. In survivorship, we need every person who's been diagnosed and treated has to go back to the primary care with a survivorship long-term care plan. I don't know how many clinics I've heard who say cancer patients come back. I don't ever even know that they had cancer. I don't have a care plan. I don't know what medicines might interdict what I'm trying to do. So I think that all of those are crucial along this continuum. Any last word from each of you, and then I'm going to bid us adieu.
I would like to empower all our patients who are listening, or family members of those patients or survivors, to see that regardless of what your background is, educational or geographical background, you have a lot to bring to every table. And we need people to be not only seated at the table, we always get invited to the table and we don't have enough people to sit at the table. But once we see these people at the table, change is going to start happening, because they're going to be listening to all this variety of needs that we have, because we're not the same. And it's so important that, Mabel mentioned earlier, it's not many of us doing this job, especially as Latinos. It's not many of us working as health providers.
I'm sorry. So what you're saying is that we not only have to be at the table, but we have to be fierce when we sit at the table.
Exactly.
We have to have opinions, ideas, and we have to say that what the community needs and where we're going to go. My bad.
Yeah.
No, I think the only thing to add, which I'm very passionate about, is making sure that I'm a mentor to those that are coming. I would love to see more Latinas doing what I'm doing.
Good.
And I think it's possible.
Thank you.
Patricia.
I think that to be able to reduce the disparities along the cancer care continuum, we need to work together. We need to involve the community. We need to involve all the key stakeholders, and to be able to develop and implement interventions that promote coordinated patient-centered care, that we need to diversify the workforce, of course, and we need to promote community advocacy so we can really promote changes in the health system and policy changes that are going to level the field for our Latino community to have access to high quality cancer care across the cancer care continuum.
And that's the perfect place and time to end it. Thank you all very much. I appreciate both your work and your passion. Thanks. We have you in the arena, Doctors Chalela, Mardones, and Lopez. I'm Isabel Duran. Thank you for joining us. Now let's go to a break.
Thank you.